Hello, my name is Robin Banky, and for my pediatric rotation in-service project, we will be discussing the human papillomavirus vaccine. Learning objectives we will be covering include briefly summarize the causes and clinical presentation of human papillomavirus, outline current preventative options for HPV, including the new HPV vaccine and vaccination schedule, and evaluate clinical literature regarding HPV vaccine delivery practices by primary care physicians. For a little bit of background over HPV, the human papillomavirus is the most prevalent sexually transmitted infection in the United States. HPV affects approximately 79 million Americans with about 14 million new infections each year. 80% of sexually active women will have a high-risk HPV infection by age 50. Most HPV infections, about 90%, will go away on their own within 2 years. HPV can cause several types of cancers, including cervical, vaginal, and vulval cancer in women, penile cancer in men, and anal and oropharyngeal cancer in both men and women. HPV is estimated to cause nearly 35,000 cases of cancer in both men and women every year in the United States. Risk factors for HPV infection include number of sexual partners. The more sexual partners you have, the more likely you are to contract an HPV infection. Rarely or never being screened for the HPV infection. HPV persistence, which is the most important risk factor for cervical cancer precursors and cervical cancer independent of other risk factors. The longer high-risk HPV infection is present, the greater the risk of high-grade squamous intraepithelial lesions, or HSIL. The peak age for HPV infection is in early 20s, and since it takes decades for HPV infection to lead to invasive cancer, these cancer peak prevalences of HSIL is usually around 30 years, with the highest cancer risk at ages 45 to 60. Other risk factors include early age of sexual activity, as well as immunosuppression, things like HIV or long-term high-dose steroid use. To discuss some symptoms of an HPV infection, while most HPV infections do not lead to cancer, they more commonly cause skin or mucous membrane growths or warts, most commonly genital warts, which can be seen as flat lesions. They're small cauliflower-like bumps or tiny stem-like protrusions that may appear on the vulval, anus, or cervix in women and penis, scrotum, or anus in men. Rarely do they cause discomfort or pain, but they may itch or feel tender. There's other strains of HPV that may cause common warts, plantar warts, or flat warts as well. But oftentimes, HPV infections are asymptomatic. Some ways to prevent HPV include safe sex practices, so the correct use of latex condoms can lower the chances of contracting HPV, but it is important to note that HPV can infect areas that are not covered by a condom, so they may not fully protect against getting HPV. Dental dams are often used to prevent STIs from oral sex, including syphilis, gonorrhea, chlamydia, hepatitis, and HIV. However, these practices will not protect individuals against HPV, herpes, or pubic lice. The Gardasil 9 vaccine, which currently covers HPV types 16, 18, 31, 45, 52, 58, 6, and 11, may also be given. There are more than 100 types of genital HPV strains. However, 13 are considered oncogenic and are referred to as high risk. Included in those are the types 16, 18, 31, 45, 42, and 58, which are in the Gardasil 9 vaccine, while types 6 and 11 are the most common strains known to cause genital warts. Additional prevention methods: women should receive cervical screenings via Pap test or Pap smear. Pap test look for the precancerous or abnormal cells, along with an HPV test that will look for the virus causing those changes in cells. If a Pap test is positive for HPV, most infections will clear on their own. However, follow-up Pap tests will be performed at 6-month intervals until the individual has 3 consecutive normal results. If the HPV is detected after the initial screening, so at that first 6-month interval, a colposcopy may be performed to visualize and remove any abnormal cells. However, it should be noted that there is currently no screening available to detect the HPV infection in men. Going a little bit further into the Gardasil 9 vaccine, the vaccination schedule currently shows that ages 9 through 14 will receive either a 2 or 3 dose regimen, consisting of the initial vaccine given at first visit and a second dose given either 6 or 12 months after the first. If the second dose is administered earlier than 5 months after the first dose, then a third dose will be given at least 4 months after that second dose. That's where that 3 dose comes in. For those 15 years and older, it is recommended that they get a 3-dose series, and that will be at the initial visit, 2 months later, and then 6 months later. This vaccine is available as a 0.5 milliliter suspension for injection, as a single-dose vial and pre-filled syringe. Contraindications for use of the Gardasil 9 vaccine include hypersensitivity to yeast, or if they have a hypersensitivity reaction after a previous dose of either Gardasil or Gardasil 9. Common adverse reactions that should be told to the patient and parent include injection site pain, swelling and redness, headache, fever, dizziness or fainting, nausea, and muscle or joint pain. Now we're going to talk about an article that was the first national survey of physician attitudes regarding the new Advisory Committee on Immunization Practices recommendations for the 2-dose schedule of the Gardasil 9 vaccine in younger adolescents. So the objectives of this study were to examine current delivery and communication practices regarding the HPV vaccine, attitudes towards and experiences with the HPV vaccine delivery, rates of refusal and deferral of the HPV vaccine, perceived barriers to delivery of the HPV vaccine, as well as knowledge, practices, and attitudes regarding the 2-dose HPV vaccination schedule. A survey was given nationally to representative networks, either via internet or mail, from July 2018 to September 2018. The internet group was sent an initial email with up to 8 email reminders, and the mail group was sent an initial mailing with up to 2 mail reminders. Non-respondents in the internet group were also sent up to 2 mail surveys in case there were problems with the email. They used a 4-point Likert scale to assess physicians' strength of recommendation of the HPV vaccine for patients in different age groups, physicians' frequency of using different vaccine discussion styles. Discussion styles were classified as presumptive if they reported almost always or always introducing the HPV vaccine by saying, we've got 3 vaccines today, Tdap, HPV, and meningococcal. Or conversational style if they reported almost always or always saying, are you interested in getting HPV vaccine for your child today? They also looked at physicians' perceived barriers to vaccination and extent of agreement with statements about the change from the 3-dose to the 2-dose schedule in younger teens, and physicians' experience with the HPV vaccine delivery. Moving into some results, the overall response rate for pediatricians was 70%, and for family practitioners was 60%. 52% responded via mail, and 48% responded via internet. As far as presumptive versus conversational style goes, pediatricians used more of the presumptive style, with 65% being in that category versus 16% in the conversational style. Family practitioners, however, 42% use the presumptive style and 24% use the conversational style. Looking at the delivery and communication practices by age group, so in the 11 to 12-year-old patients, strong recommendation for the Gardasil 9 vaccination for females was 85% strongly recommended by pediatricians versus 72% for family practitioners. And for males in the same age group, the pediatricians strongly recommended vaccination in 83% of patients versus 66% with the family practitioners. In the 13 to 14-year-old patients, pediatricians strongly recommended vaccination for females at 98% and 97% for males, whereas family practitioners in that same age group strongly recommended vaccination for females as only 87% and 79% in males. For those 15 years and older, pediatricians strongly recommended vaccination for 99% of females and 98% of males, whereas family practitioners only strongly recommended this vaccination for 90% of females and 83% of males. The remaining percent not included on this chart fell into either recommending the vaccination but not strongly, making no recommendation, or recommending against the HPV vaccination. Regarding attitudes and experiences with HPV vaccine delivery, a majority in both specialties strongly agreed or somewhat agreed that it is important for individuals to be vaccinated before engaging in physical intimacy. They encountered more resistance to HPV vaccination compared to other vaccines since it is not required by schools in their state, and they encountered less resistance from patients and parents to beginning the HPV vaccine series at ages 13 compared to those at age 11. Approximately 1/3 of physicians reported anticipating uncomfortable conversations if they recommended this vaccination at ages 11 to 12 years old. There were high rates of refusal or deferral among the 11 to 12-year-old patients. Family practitioners reported higher rates than pediatricians at all ages, and both physicians were significantly more likely to report refusal or deferral for their male patients versus their female patients. Some factors significantly associated with physicians reporting the 50% or more refusal or deferral rate among that 11 to 12-year-old group included not strongly recommending the HPV vaccine, not almost always or always using a presumptive recommendation style, strongly agreeing that they encountered less resistance to the HPV vaccination from patients 13 years or older, and anticipating that uncomfortable discussion when recommending to that 11 to 12-year-old age group. Some perceived barriers to the HPV vaccine. So 20% or more physicians in either specialty reported major perceived barriers as either misinformation parents received from the internet or social media, parental concerns about the safety of the vaccine, parents not thinking the vaccine was necessary for their child, and opposition to the vaccination for moral or religious reasons. Physicians were frequently incorrect or reported not knowing the number of doses recommended in different scenarios, or whether additional vaccination with the 9-valent HPV should be offered to those already fully immunized with the 2 or 4-valent HPV. The majority of physicians strongly or somewhat agreed that the 2-dose schedule is as efficacious as the 3-dose schedule for those less than 15 years old. However, more than half of family practitioners and roughly 1/3 of pediatricians strongly or somewhat agreed that having different recommendations for individuals 15 and older created confusion among patients and parents as well as practice staff. 74% of pediatricians routinely recommended second dose HPV 6 months after the first, compared to 88% of family practitioners, and 25% reported routinely recommending it at 12 months compared to 12% of family practitioners. And it's important to keep in mind that either 6 months or 12 months can be used in this vaccine series. In conclusion, this survey suggests improvements are needed in how the HPV vaccine is being recommended. AAP guidance includes use of strong pediatrician recommendation with wording that is consistent with a presumptive style, and the AAFP website offers family practitioners to Centers for Disease Control and Prevention talking points that include recommendations for same-way and same-day adolescent vaccination. The 2-dose schedule could result in a meaningful increase in HPV vaccination initiation and completion among adolescents, including leading to a greater protection against HPV-associated cancers in the United States. Additionally, physicians should still discuss with parents and patients the benefits of vaccinating prior to sexual activity.